Well, welcome. Welcome to the DeBakey Institute for Cardiovascular Education and Training. And welcome also to a new series that we're producing called CV Live, coming to you from Houston and deep in the heart of Texas. This evening I'm joined by my friend and colleague, Dr. Ponraj Chinnadurai. He is one of the senior research scientists for Siemens Advanced Therapies. And he's taught me a lot about how I think about imaging and how we integrate preoperative imaging into actual therapy for the patient. And so tonight we're going to bring what he's taught me to you, and hopefully we can teach you something. So if I could have my first slide, please. Let me just start off by level setting a little bit of the background knowledge. We're going to talk about the diagnosis of endoleaks, not so much tonight about the therapy for endoleaks. That's something we plan to cover in a subsequent webcast. But we'll touch on it a little bit and kind of point to the importance of advanced imaging. So a little bit briefly about endoleak classifications. For most of you, you're probably already aware of this. Lots of ways pressure can get inside an aneurysm sac, and we're going to focus tonight really on abdominal aortic aneurysms. Again, subsequently we may talk about thoracic. A type 1 endoleak is obviously where flow occurs directly into the aneurysm sac, either around the proximal or the distal attachment site. We'll come back and talk about type 2, since that's going to be probably the main focus of the discussion tonight. Type 3 is from nodular disconnection. Type 4 is sweating or a hyperfiltration basically through the wall of the endograft. And type 5, sometimes we can't even identify where it's coming from. But the most common type, and perhaps the Achilles heel of endografting, is the type 2 endograft. And we often diagnose this either by ultrasound, in which case here you can see an aneurysm sac which has been excluded, flow is occurring through the limbs, and sometimes it's pretty obvious that there's flow. In this case, it's a type 2 endoleak from an inferior mesenteric artery. The question is, which direction is that flow occurring? There obviously has to be inflow and outflow. And we're going to see whether Ponraj here, working his magic, can actually help identify exactly what those flow characteristics are. And we always go either lowly lumbar artery. Now, we as surgeons have dealt with lumbar arteries, and when we open up an aneurysm surgically, all we do is put a bunch of stitches in that and we oversew those lumbar arteries. But those lumbar arteries, who would have thought we'd become interested in the anatomy of the lumbar arteries? And as you can see here, this is from a cadaver. There are a whole bunch of lumbars. Sometimes there's one stem, splits into two arteries. Sometimes they're completely separate. And a lot of this focus now is on what the importance of these lumbar arteries are. Should we try and shut them down? Or how do we control the development of type 2 endoleaks? And this is from a case that I did. And you can actually see the endograft is under my hand. And that blood that's squirting when we've opened up the endograft, and you can see that some pretty good pressure comes in, and this is just one lumbar artery. Sometimes there are several of these. That alone can be enough to cause the aneurysm sac to enlarge. And if it doesn't, it certainly can be picked up on a CT scan, and it drives ever more imaging. And so we're going to talk a little bit about this, and I'm going to give you a teaser here for what Ponraj is going to talk about. Because here's how we think about when we're troubleshooting endoleaks. We review the pre-implant CT scan. Was there something in the CAT scan there, such as calcification or a ledge or huge IMAs, that we should have really been more cognizant of? Look for lumbars. Is there an accessory renal coming out of the aneurysm sac? We look at the implant zones and the seal zones, because what you really don't want to do is miss a type 1A or B endoleak. And then increasingly we're doing what we call dynamic CT, and that's going to be one of the features of what we're going to talk about a little bit tonight. So let me show you what I mean by a dynamic CT scan. This is a patient who we're doing, and you can see the inflow through probably the L4 lumbar and the outflow perhaps through the L3. Yeah. And that lets us know exactly what perhaps the predominant flow is actually occurring. And we're going to talk a little bit about that. There are also other branches that we got to deal with that can contribute to this, that we've certainly got to be aware of. And the cartoon you're looking at to the right is one of the ways when I'm dealing with the type 2 endoleak, and we're going to deal with this. There are a variety of different ways we can approach this. Obviously, we only approach it if the aneurysm is getting bigger. And our approach depends upon the configuration of that aneurysm. Where is the endograft sitting? and what is the target vessel. And so by identifying, so for example, in the top left, you can see we're looking for an IMA source. The endograft is posteriorly. We can approach it translumbar from the left. Sometimes we actually approach these things from the front, and it's all based upon what is the potential access, where is the endograft, and what is the target vessel. And that's what Ponraj is basically going to help us with. So for example, this is how we do translumbar approach. Here we use iGuide from Siemens. That's what the green imaging is. This is all done on a workstation. Ponraj is going to show you how we interact with the workstation. And in this situation, we know it's 14.5 centimeters from skin to target, and what the approach is going to be here going through the psoas muscle. And on the angiogram on the right, you can see we were targeting an IMA, and we actually managed to access the IMA. We've been doing a lot of these transabdominal, and here we actually use surface rendering to help us choose what that approach is actually going to be. Sometimes we do this through a laparoscope. Sometimes these aneurysms are so big they're right up against the abdominal wall, and as long as we can be sure no colon in the way, then we use this iGuide system with a laser guidance system to drive a needle straight in through the anterior abdominal wall into the aneurysm sac. And one of the advantages of an anterior approach is the targets are more often than not, the lumbar arteries, and that gives you a straight shot into the lumbar arteries. Just packing the aneurysm sac per se doesn't really help. Here's a patient that we did a transcaval approach, and that little green circle that the catheter is on top of was selected by Ponraj and myself looking at the preoperative CT scan, and all these funny looking lines are actually the lumbar arteries, and you can see we're lining up that target. That's the area where we've chosen to traverse from the cava into the aorta. And here, this is an AP view now, and you can see that that catheter has been driven into it. We're shooting from the aneurysm sac, and you can see Ponraj has worked his magic and clearly delineated those lumbar arteries. That was all mapped off the CAT scan. Another way of trying to do this, of course, is with a paragraft approach. This may be a little horrifying, that sometimes this is a lot easier than you would think it would be. You can actually jam a catheter up against the wall of the iliac and then access and drive up in a paragraft alongside the graft into the aneurysm sac and potentially drive coils that way. So these are the different ways in which we can actually approach this, and but all of them are predicated for us on the preoperative interrogation and the planning for this. And now, as I hand off to Ponraj, I want to acknowledge Dr. Suman Chang and the techs who are involved in the CT in the Cardiovascular Imaging Center, because they're heavily involved. And I think that's a theme that you're going to hear about, is the communication to the techs and to the physicians who are interested in the diagnostic phase of this to try and acquire these scans. This is not just the genetic scans. So Ponraj, why don't you tell me a little bit about how we should be imaging before we get into the interventional suite to try and take care of these endoleaks?
Sure. Thank you very much for this wonderful opportunity. I'm very grateful to be here sitting in this first edition of CV Live and sharing what really I have learned by spending 8+ years in the operating room and learning about how can we make these surgical procedures really better by utilizing all this imaging technologies. So the concept we are trying to address here is, this is a great example for how, being in the field, working very closely with the surgeons, we were able to address the diagnostic pathway and imaging for these patients. So the concept we are going to talk about is targeted specific imaging, or clinical task specific imaging. And this is a classic example because aortic endoleaks, as you mentioned, is a Achilles heel, and this is not doing the justice for all the advanced endovascular stent graft technology if we can't solve this problem by imaging.
So I think one of the principles that you've taught me is that when we come down to acquire an image that we are going to use to drive therapy, then it's not just a generic CT scan. We need to tailor that scan to answer the question that we can then use that to solve the problem for the patient.
Yeah, exactly. Typically, the radiology machine works by standardizing the protocol, and what we are doing, or what we are trying to go towards, is maybe deviate away from the standardized machine-based approaches towards customizing the protocols to the clinical task or the clinical question that you're trying to answer. Because these patients are getting CTs every year as follow-up, so we know exactly where they are.
So when you say machine, you're not talking about the scanner, you're talking about the way we push patients through a very standardized protocol, almost regardless of what the diagnosis is.
Exactly.
Okay. All right.
And that's where, so before we go into the cases, I thought I'll give a couple of slides on the imaging protocols of how we scan these patients. So to illustrate the concept, what I decided to do is, so this is us selecting the protocol, and here we select the parameters, but before we go there, I just kind of wanted to illustrate this concept. Without a patient on the table, what you're seeing here is a clock with a second hand in our CT scanner table. And typically, if it was a patient, this is our typical contrast injection protocol. They get a brachial or the IV line access, and we inject roughly around 70 cc's of contrast. And here we are acquiring, instead of a standard triphasic scan where you get if you get a CT in a regular hospital, or a standard protocol is, you get a non-contrast scan, you get an arterial phase, and you get a very delayed phase. And this delay is a subjective term. There is no standardization for this delay.
And the delayed phase is the hope that the delayed phase is timed with blood or dye arriving in the aneurysm sac.
Yes.
But if you mistime that,
Yeah.
it may look like there's no endoleak.
So if the patient has a type 1 and a type 2, and if we took our delayed picture earlier, we only will detect type 1. We might miss type 2. If we took a later picture, we might miss an early type 1, and we probably might see only type 2. Or even the dye might have washed out and we may not see anything at all. We might falsely say, oh, the patient is fine, but the aneurysm might progress. So these are examples of how the clinical challenges we face and how we can use dynamic imaging technologies. I know by dynamic imaging, there is a transition, or a common analogy we can say is taking 3 pictures to, instead of taking 3 pictures, we take multiple pictures and stitch them together as a video. Yes, of course, it comes at an additional cost of radiation, but because our scanners have become better, we can do low dose reduction factors such as lower kV imaging, or sampling our time based on the clinical question that we are trying to answer. So this video will hopefully illustrate the concept that I'm trying to take. So here is a clock with a second hand, and we are trying to image the second hand movement every 3 seconds. And this is exactly what is happening when a patient is being scanned. The patient is lying on the table, and we are basically shuttling the table in and out to capture the region of interest and acquiring images, shooting x-rays while this movement is happening.
So let me ask you, one of the questions I always get when, particularly when we show dynamic MR, is you must have some really fancy machine. Is this a really fancy machine?
Well, one thing I want to be clear is, even though I'm a research scientist, these are commercially available products. So, but the part that we are able to get through the barrier is understanding what is it the patient really needs and customizing our protocols. And once we have a few protocols, depending on the patients, we learn the first 10 or so cases, and then now we are at a point where we know what we can exactly do for the next patient onwards. So let me show you quickly what kind of images we get before showing any patient images. So this is the scan that we took, and just to orient, you're going to see the same interface for our clinical cases as well. So you see the short and long hands and the second
so
clock.
you scanned the clock. Okay, now I get you.
So instead of imaging at, say, 12 o'clock and 12 o'clock and 15 seconds and 50 seconds, taking a guess, we are taking pictures every 3 seconds. And that's what I'm going to, as I move this slider here, I'm going through 2.5 seconds, 5 seconds, 10. So you can see the clock moving, right? So this is the concept. This is, in theory, this is what is happening, and this is what we are able to generate.
So this would be, instead of the clock, think of the aneurysm and the endogram.
Exactly.
Okay.
And this is not a 2D picture, this is a 3D volume, as you can see. I can rotate around and see the entire clock, right? You can even see the batteries of the clock and the mechanics of it, right? So it could be a great topic for a mechanical engineer.
Right.
So, and again, the point here is to show that by dynamic imaging, we are not missing any critical information. So let me switch to a patient.
So my bias is, you know, the cardiovascular system is incredibly dynamic.
Yeah.
I mean, I think we're going to look back 10 years from now and go, why would you ever have static images? And you're on the forefront of trying to figure out how we send this message about the importance of this. And number 2, a lot of people can do this. They just don't know they can do it. It involves a little bit of time and effort and energy setting up the protocols. but it can be done.
Yeah, most scanners have, independent of the vendors, have this capability. The only limitation we will have is how much slices we have in our CT scanner, because the detector width determines how much we can cover from head to feet. If you wanted to cover the entire stent graft, if you have only a 16 slice scanner, you are limited with in terms of how much Z-axis coverage or long axis coverage that we are talking about.
So I think we're very fortunate, and the imaging is all inside the Heart and Vascular Center.
Yeah.
Dr. Chang basically is a cardiologist, one of our partners, and it's a matter of me communicating what I need to know, and he can tell me whether he can do it or not, and then basically get somebody involved in producing that.
And almost always, unless this is the very first scan, I mean, which very rarely happens, we always have imaging data. Even we can use the scan that was acquired before the stent graft was put in to understand the anatomy. So unless and until, I mean, almost always we have some prior data to target our region of interest, so to say.
Now, I do want to mention that people can call in and they can ask us questions. Actually, we're more than happy to take questions in the course of while we're doing this.
Okay, yeah, and that's something I also encourage, because this is not a canned presentation. There is no PowerPoint in front of me. I'm doing the routine post-processing that we typically do before every case in the operating room.
So here's how it usually works. I'm in the clinic and I see a patient, the aneurysm is getting bigger. I call Ponraj, say, okay, this patient's got an endoleak. He helped set up this protocol with Dr. Chang. We route those patients specifically to Dr. Chang. He acquires the image, and then we sit down before we're going to do the case and figure out what we're going to show you. I mean, what we're going to show you is really how we go through setting these cases up.
So one advantage here is we are today talking about in the context of endoleaks, but this imaging can be applied to any dynamic disease process, whether it is dissections or peripheral artery disease. So maybe there are much more clinical benefits there, but this is just a concept, a way to explain how we are able to use this technology to...
I love the clock.
Okay,
I thought this was a generic clock. I didn't realize you were scanning this clock.
Okay, let's go to the patient. So this is a 76-year-old male who got a Z-fen, or fenestrated stent graft, put in maybe a year or so ago, and the patient came back last year in August for a routine endoleak scan. And this is the routine protocol that I was talking about. Non-contrast scan, showing the right and left renal stents. As I go down, you see the, sorry, I'm going up. As I come down.
So the non-contrast scan from our standpoint is particularly useful to look at the metallic components of the stent.
Yeah. So you can understand the construct or a morphological construct of the device from this scan, and it also helps. For example, if you didn't have non-contrast scan, we might think that is a contrast and opacification.
Looks like contrast.
It is not contrast because it is there in the non-contrast scan as well. So, and you can see that even in the other two phases. This is the arterial phase. You can see the contrast in the aorta, and this is a delayed phase where it is a little fainter. And I can't tell you exactly, but I can tell you, say, this is 11:49 and 11:50. So this was roughly a 1 minute later scan. So if
so let me ask you one question, because you have these synced side by side, comparable slices.
Yes.
How do you do that?
So you load them into what we have. We have certain workflows where, because the patient didn't move during the scan, we know exactly which slice position corresponds in the non-contrast to the arterial to the delayed phase. So these are all, I would call it as time synced for now.
Very good.
And here, as we come down towards the sac, you can see this faint contrast opacification, and even towards the neck, there was some contrast opacification. As you can see in the arterial phase, there is some contrast right at the neck. And as I come down towards the sac, so here you see, I'm zooming in towards the bottom end of the graft. It's very difficult to really tease out where this contrast is coming from. I mean, you see a lumbar artery here, but you don't really see where exactly it is entering the sac. And again, sometimes this may not be sub-millimeter slices. So it really depends on what you get what you ask for. If you ask for 1 millimeter cuts, because we are looking at, you showed in our open surgical example how tiny these vessels are. And if we are doing a 5 millimeter CT, there is a chance that this origin of the lumbar artery to the sac might be missed or averaged in that 5 millimeters.
Okay.
So this is, I just wanted to show that this is the standard of care in any hospital that doesn't do dynamic imaging for endoleaks. So now let me switch to the dynamic images. So this is just one representative image of a dynamic scan.
Okay, well, hold on. You got to tell us what we're looking at. This is not just any ordinary scan that we're looking at here.
So what you're looking at here is an advanced cinematic rendering of an arterial phase. So I picked one phase where there is the lumbar artery is visualized well. And you can relate, I'm pretty sure you can relate this to the surgical field.
Okay, yeah, sure, but I mean, cinematic rendering, you and I know what it is. So what is cinematic rendering?
Okay, let me dial this down before I get it back up. So when you acquire axial slices in CT scanner, you can put them into 3D rendering, just like any 3D cameras. So this is the standard volume rendering technique. Here, as you can see, it is a 3D volume as I rotate around, but what we lack here is the depth. Right? Even though when I rotate, you know this is posterior going back, and when I'm in the anterior, if I put these two vessels overlapping, the SMA branch and the lumbar, they look almost on top of each other. But when you do cinematic rendering, you do some advanced lighting and try to see the depth. So here, once you switch, so I switch to the cinematic rendered mode, you get the depth perception, which probably a surgeon can relate to when you operate. So any structure that you might come across in the surgical field can be brought in here. So for example, if I bring the volume up, if I get my clip plane out.
So it takes a moment or two to do this.
Yeah, because I'm running in a Wi-Fi in a laptop that's doing all this processing in a server that is remote.
So it's not done in your computer?
No.
Okay, so what happens?
This is just a viewer that we have that you're looking at, and you see the muscle, you see the ribs, and as I window this out, and you will see that. So you see the rectus.
Yeah, just let it sit for a minute.
Yeah.
Because one of the things we've been also interested in is how do we push images like this. Now, again, when you get a CAT scan, another thing you taught me, you're on that CAT scan. We typically look at cross-sectional images, but if we surface render it, we can see the patient. And we're really interested in how we take these images in a non-hybrid room environment, fuse them, and use this for surgical planning.
Okay, so in my standpoint, if a patient got imaging data, the patient deserves guidance to surgeon for any procedure from that data. It's like leaving your map at home and going exploring in the back country.
Yeah,
right? So this is your map for the surgical procedure.
So what's happening here is this is pushing up to the cloud, the rendering has been done, it's coming back down. So it takes a minute or two to do it. It's not immediately beautiful. It takes a little bit of time basically for the rendering to occur. And the whole idea is to make it look like anatomy. Not look like black and white fuzzy images that you need magicians to interpret.
Well, although this is a great picture, but this is generated from the source data. When we are making diagnosis, this is a good picture to get a rough overview before you walk into the procedure. But the real data still lies on these cross-sectional images. So what I'm going to do is go through a standard process. This is exactly how we do in the clinic, reviewing these cases, or even in the OR. So this patient got a dynamic CT for evaluation of endoleak. So we are going to go through the top end of the graft.
Before you start doing that, I think we need to take a commercial break for 1 minute.
Okay.
And then we'll come right back.
All right.
And then we're going to drill down into how you actually do this.
Sure.
Good start.
Thank you.
Thank you.
I'm so excited. I got a chance to go through the lab and actually touch a piece of Gore-Tex, which my son has Gore-Tex in his body. And I got a chance to see how the valves are actually put inside the heart in the catheter, with the catheter.
Well, I was really interested in the cath demonstration because we actually got to put the guide wire in and to actually see what it really looks like was pretty amazing.
Most people love seeing and feeling and knowing what's going inside their body. They want to keep abreast of the technology. It's almost like watching Star Trek in front of them and seeing what's going to happen now, 5 years from now, 10 years from now, 50 years from now, perhaps.
One, I think it's really, really helpful to get to see all of the industry partners. They get to ask the questions from the companies and not just the doctors, and get to see all the stuff and touch it and feel it and play with it. And when you can, really put your hands on it, it puts it in a different perspective.
You get a chance to see state-of-the-art technology that is being used. You get to hear from the best of the best doctors. I mean, they even fly doctors in from all over so they can come and share information with the parents and with other professionals.
It is a great opportunity for young trainees like me to interact with world-renowned experts. These kinds of events promotes awareness to learn and understand the physiology better.
We're not exposed to congenital heart disease in our everyday training and practice, so it's really nice actually have a hands-on experience on the cutting-edge technology.
For physicians to have a better understanding of the disease process, then they're more likely to know what the issues are, and also they will be more likely to channel them to the appropriate providers who can provide them the appropriate care. And for family members and patients themselves, this is such a great way to obtain social support, so they feel like they're not alone in what they're dealing with.
And I tell my friends what Alex has gone through or what he may face in the future or what it's meant to us, and they sympathize, but they can't really relate. And so one of the reasons to come here is the invaluable face-to-face time you get with others who've been through the same experience.
Okay, so welcome back. Now we're going to delve into the meat of this presentation. Ponraj, over to you. Show us how we are going to interrogate this graph.
All right, let's follow a protocol to go through and evaluate the data set. So this patient was scanned for a possible endoleak. So we're going to typically look for type 1A and type 1B. So right now what you're looking at in this top 3 panel is the sagittal, axial, and the coronal views of which are aligned to the top of the stent graft. And once I'm zoomed in, so as I go up, so now we are in the native aorta, and that's the top end of the device. And this slider, as we saw in our previous clock example, as I slide to the left,
What's time?
so now that's the time 0.
Yep.
So now time 2, 4. So here we scanned at every 2 seconds. So this is 6 seconds. So what this enables us to do is kind of create an angiogram at any angle that you can. Right? So that's essentially what this does. Typically what we do, we go to AP and go to LAO and look for this particular contrast and try to see it. So if I zoom out, we can try to see if any of these contrast is getting into the sac. For example, here you see the left renal stent projecting into the lumen. At any view, we should be able to go from arterial to the late phase. So all I'm looking for now is this filling from the top end of the graft right here. Right, and same way if I bring it down all the way to the top end of the stent graft, and this is where the aneurysm is expanding, and let's see if there is any filling.
So you're going to give me the time course of what happens right at that spot.
Exactly. So this, number 1, for sure rules out
Type 1
endoleak.
Don't see any flow there.
In supine position.
Doesn't look very well opposed, but it's clearly not getting down. At least flow isn't occurring down in the aneurysm
exactly.
sac. Okay.
And since we also have a long seal zone, it's very well opposed here, and it's probably maybe not well at the top, but you have enough seal zone along the neck of the aneurysm.
All right, I'll buy that.
In the interest of time, you essentially do the same thing for both limbs, right iliac, left iliac, go through the time point, you rule out type 1B endoleak. So now coming to the most important part of finding the type 2 endoleak, which is, again, I'm going through the process so that way we do the same thing in all our cases. So now as I go down towards the aneurysm, all I look for is...
So let me ask you a question. Can you do the same thing at the renal stents to make sure basically there's not a junctional leak?
Yes.
Okay.
You can align to the renal stent. So if it is, for example, filling retrograde from the renal artery, you would see...
So we've seen retrograde flow around renal artery back into the aneurysm sac. It wasn't it need to be redilated inside the renal artery to seal it.
Or extended further down here. So here we don't see any contrast even if I go down through the time point. Right? Did that make you comfortable for ruling out type?
Pretty comfortable.
Okay. So now let's look for the type 2 endoleak. So here...
I mean, the reality is a pretty big deal to go back in and redilate the neck.
Yep.
is tough, because now you got to cannulate both renal
Both.
arteries. You got to protect them so you don't squash them when you put the balloon in there. Okay.
So,
So that's very helpful.
so now I go to an arbitrary mid time point where I know for sure I can see it. So it's kind of like going through the midline of the time frame, time attenuation
So
curve.
let me ask one. How long do you know how do you know how long to image?
So this is something that has been studied. This is not novel. People have done dynamic CT imaging. So here we are talking about how this all ties to the final procedure. But at least this dynamic imaging has been available for cardiac perfusion imaging as well, or peripheral perfusion imaging. So it really goes by the hemodynamics. And we don't know, but there have been studies that looked at patients that say, okay, if you start your acquisition from say 4 seconds or so, 4 to 6 seconds, you get a good arterial phase, and then if you stop at 20-25 seconds, you probably can rule out the inflow from IMAs, lumbar arteries coming in. So that's kind of the there is no hard set rule. If the patient has a poor cardiac function or low ejection fraction, then we have to time it to that patient. So we haven't come through that challenge yet, but for example, here we only have imaged until 52 seconds. That's already quite a lot. And there is still, by no means we have come to a set protocol. This is a learning process. As we learn, we evolve, and we reduce our radiation, and we also kind of identify what is that sweet spot that we could image. So once we see contrast opacification in one view, we can go back and look at in the other views, and again the same process of going through the time points and see if there is anything. Do you spot something in this image as I go through the slices?
You're going to put me on the spot, huh? Mm. Well, yeah, I mean, obviously I can see, well, maybe a lumbar posteriorly, but you can see the endoleak cavity fill. Now, I would look at it basically in the coronal sagittal planes to see if it's filling from bottom to top, top to bottom.
Exactly. So that's what having this three-dimensional data, three-dimensional data can give us. So here, all I'm doing is using the sagittal view to align my orange line to the endoleak. So now, to answer your question, is it filling top down or bottom up? Again, as I go through the time point, time 0,
very good.
It fills bottom going towards the top. And in the axial view, we saw a lumbar artery that was filling, which is
beautiful.
This vessel. So we actually could trace this coming into the sac. You can see that little piece of calcium. So it was filling through this. So there is some blooming artifact as I window it out.
It's from the calcium alone?
Yeah. There is a little break in the calcium, which you see. We'll see it better in our 3D image. And the artery fills through it. So if I play my timeline here, time 0 towards the arterial phase, you can see the artery filling, and then it's filling. And now the other thing is you can also go quantitative here before we go to the treatment part. What I wanted to show is if we put a time attenuation curve. So imagine now we can derive these numbers from these frames. Let's say if I put a circle on the arterial phase, and this is on top of our endoleak, or maybe
so you're looking at arrival times.
Yes.
Contrast arrival.
Contrast arrival time. So because we have these, let me delete the last one. So now we have, maybe I have some results from the last 3 times. Okay. So now we have 3 curves. Okay, so these are the 3 curves that I measured. So number 4 is our arterial phase. So you can see the early peak and the late enhancement. So this is where this is the peak of the arterial phase, and this is the peak of the endoleak cavity that we saw.
The top one?
The top one, the blue.
So it's delayed.
It's delayed.
Seems like it's more dense.
Yes. It is more dense, but that probably is an indication of how much flow we are getting through that lumbar artery that we have. And then once we have this information, now it all comes down together in the 3-dimensional space. So we looked at the raw data, and now the same process, if I go through the renderings here. So you can even see the, if I zoom out a little, you can even see the SMV. So in the early arterial phase, SMA filling, and you get the SMV and the portal. So that already is a good indication that we covered pretty much the entire contrast kinetics from the arterial through the venous bed. So, and here we are seeing this contrast filling from this lumbar, L4 lumbar, getting in the sac and then exiting out through here. All right.
Very good.
So this is all done in the physician's office. Once the scan has been done, immediately after the scan is done, we know exactly what the plan for the surgical procedure. So now what we can do is how we can utilize this information. It's like a map. We created a map. Now we have to figure out how do we get our treatment. So what are the possible ways we could treat Dr. Lumsden?
So I guess and the principles of this are that, and this remains to be proven, if we get the inflow artery, we're more likely to be successful than just filling up the endoleak sac, or the endoleak space. I've done a lot of this, and it's kind of a thankless job. I always say it's like you plug the leak here, and the problem arises somewhere else.
Somewhere like a whack-a-mole.
In theory, this should help me be a little more specific, but I think, in all honesty, that remains to be proven, that targeting these actually makes us more effective long term.
That is true, and that's what the power of technology. So let's say you embolize this and you repeat the scan 1 year later or 2 years later if the aneurysm is expanding. Now we know exactly where the next source of endoleak could be, and this is a work in progress that we could definitely do more of these and understand, is it enough to occlude only the inflow? And this I can relate to my limited experience in neuro. When we treat AVMs, there's always the same challenge. You go for 1 or 2 feeders and there'll always be a recurrence coming, feeding in from the other branches.
So in terms of what to do about this, I mean, we kind of covered a few of the approaches to start with. And so to my mind, looking at this going, is there an arterial access, for example, an ascending lumbar? These can be difficult. Is there an IMA that we can get from the SMA? Failing that, then it's either translumbar, transcaval, or we can go transgraft, perigraft or transgraft.
Okay.
I've never done transgraft. I know, the president of the ICVS, Dr. Krazier, who's one of our friends from next door at Texas Heart, that's his preferred approach. And so I think one of the future webcasts will get Dr. Krazier to come over here and tell us how to do it. So I haven't really done that. I'd be looking really to see, am I going translumbar? If there's a big aneurysm, a skinny patient, may go directly anterior, or can we go transcaval into the aortic aneurysm? Depends upon the configuration of the aneurysm and where that stent graft is inside it.
Okay, now we are going to take a virtual visit to the operating room. So this is our diagnostic imaging computer where we reviewed our scans. So what we have here is, instead of taking you all to the operating room, this is essentially the same computer that is connected to the C-arm where these imaging is acquired. So what we typically do in the operating room is go through a process of 3D acquisition or 2D 3D registration to integrate this. So this is a typical view of our hybrid operating room. Maybe Dr. Lumsden can give an overview of this. So we have been using, so what you are seeing here is a C-arm that is mounted on a robotic arm which can rotate around the patient and generate 3D images. Since we already have a very good 3D image, we don't necessarily have to acquire another set of 3D images. What I'm going to demonstrate is, can we acquire just 2 images and integrate this preoperative CT image to how the patient is lying on the table.
Okay, so the concept then is that we got a lot of information on that beautifully acquired dynamic CT. We want to be able to take that image, overlay it on top of the patient, so the image is fused, and we use that C-arm, which is the new pheno from Siemens, to either create a 3-dimensional data set. I call it the quick and dirty scan of the patient on the table. They've not been given any dye. What we're going to do is bring in the previously acquired data set and fuse these together. Conceptually, is if you take the ribs and take from the scan we've just done, no dye, take the ribs from the CTA that was done, and we align the bones in 3 dimensions, in theory, the blood vessels should be aligned.
Okay, but here we are fortunate enough to have a very great fiducial, which is the stent graft.
The stent graft. So we're going to fuse the stent graft, stent graft to stent graft.
So, and
now the other way that we've done fusion is with I will say that our patients all have bones in their blood vessels.
Yeah.
They have wall calcifications, and so
As
for
you can
TAVR,
see.
and you can see the calcification that Ponraj is pointing out, we don't need to depend upon that. We don't operate in the ribs, and we don't operate in the spine. We operate in the blood vessels, and so we need the blood vessel fusion to be very accurate, and we can do this using multiple different sources.
So you mentioned a couple of treatment options. So what we have done is identified that peak opacification data set and used that for our planning. And what we are seeing here is that exact source where that lumbar artery is coming in, and you can see that little break in the calcium that we were
So you
talking
select
about.
this and you draw on a center line. Do you
Yes.
draw that by hand, or is
Yeah,
that
so this
automatic?
this red center line is drawn by hand because of the lumbar arteries, because they have various anatomy. They have sometimes they have separate origins. They might have single origins. So here it looks more like a single origin. We see faintly the left side lumbar arteries. And what other thing that I have marked here is, if I make my slice thicker, you'll see the needle path. So that is the virtual needle path that we have planned.
So we're going to go anterior.
Yes.
This would be difficult to do translumbar because there's not a lot of space. I mean, when you come translumbar, you got to get a needle in the aneurysm sac without sticking the stent graft.
Yes.
You got to get a wire in the aneurysm sac. You got to get a sheath, and the sheath has to project into the aneurysm sac, otherwise it falls out. And then you got to get a diagnostic catheter, which can be very difficult to manipulate inside the aneurysm sac. But that's, so again, it's always a matter of, preferably not through the stent graft, trying to choose the appropriate path to give you access to these target vessels.
So here what I'm trying to adjust is, we don't want to hit the graft. We want to miss the graft, but that's why I used a caudal approach, where you can adjust our needle path so that we are just missing the stent graft, and we wanted to really enter where that lumbar artery is coming in.
We probably entered a little higher than that.
Yeah, so
I'm not that good that I can sneak it right into that little space that you got to find out. There you
all
go.
right,
That's a
so
little bit
let's
better.
go a little bit superior,
Yeah.
so where we are safer. We have this little room where we can try to get to that spot and then try to aim downwards. So, and again, once we have this 3D planning, now we are at this what we call as bullseye view. So now if I get rid of all the
So can you go back, to the
to
previous?
yeah.
So bullseye, again, all of this is planned on a workstation. That green line is where we would like to track a needle. That green line, once it's fused, is pushed up into the image intensifier.
Yeah, into
in
the
this case
X-ray
for
image.
female.
We'll see that.
Now, if you were standing looking straight down that line, that's what's called bullseye view. And Ponraj can tell the machine, the image intensifier, to look straight down like you're standing on the end of that green line.
Okay, so if we have both monitors up, we can show what's happening typically in the OR. So this is the 3D planning software, and the other feed is going to have the live X-ray image in a second. So we planned our needle path, and these are our optimal bullseye views, which you can see is achievable, RAO 26 and 27. But we haven't really fused the patient to how the patient is lying on the table, right? So we are going to do the co-registration process using 2D, 3D registration, as I was talking about.
So 2D registration is just you take X-rays and two different views.
Yeah, so for example, here we took one X-ray image close to LAO, and the other image is close to RAO 80.
And that
right?
that retractor thing is because we couldn't tell where the colon was.
Yeah.
And so we thought it was safer just to make a little incision spread, because the aneurysm is so close to the anterior abdominal wall, but it's kind of a bad day if you stick a needle through the colon and then into the aneurysm sac.
And I also want to remind that this, even though this is a dynamic data which is not acquired in the operating room, it was acquired 2 days before or 2 weeks before, and we cannot for sure exclude if there is any colon in the way. So that's another reason to have a little surgical exposure, or we can repeat another scan if the patient is super skinny. So now I'm going to go through a simulator of option where instead of having a CM, we are going to go through those two images that we have acquired. So this is the first image that I was talking about in a roughly AP projection. And now you oblique the C-arm and acquire the second image. So, and now you have two sets of images. So if I go use my slider, this is your fluoroscopy from the day of surgery. This is the CT from 2 weeks before.
So, correct me if I'm wrong, I will step away. When you see two colors,
Yes.
it's two different data sets that are being fused together.
Yeah.
So the brown one is the CTA, and the white is just a typical X-ray.
Standard X-ray image. So all I'm trying to do is get it close enough for the automatic registration to work. So I'm trying to get it, so I know where the graft is. So and once I get it close, I'm letting the automatic registration run. As you can see, it's trying to now do the rotation and translation to align the stent graft.
So this is being done automatically now.
Yeah. It involves some manual tweaking. If it is off, I mean, as always, we can check. So here you can see, if I bring the stent graft up a little more, so now we are looking at two sets of data sets, right? So you have the stent graft marker and you have the stent graft from the CT matched with the fluoroscopic image.
All right, before you get to the exciting part of us sticking a needle in here, let's take one more quick break.
Hello, my name is Ross Rule, cardiovascular and thoracic surgeon at Houston Methodist Hospital. Greetings from the Texas Medical Center. On behalf of the DeBakey Heart and Vascular Center, I welcome you to join us for the Cardiovascular Fellows Boot Camp. This will take place at the Houston Methodist Research Institute and the Hotel Zaza just down the street. This is a truly unique opportunity for first-year cardiac surgery fellows to have a crash course in cardiovascular medicine, cardiovascular and endovascular procedures, and invasive diagnostic and therapeutic technologies. This course has been described as Disney World for cardiovascular surgeons without all the lines. It is truly multidisciplinary, hands-on experience complemented by lectures, simulations, and a direct instruction from the basics to the newest innovations. This is an excellent introduction to transition fellows into the world of cardiovascular surgery, guided by world-class faculty. The full schedule of lectures, hands-on sessions, and events can be found on our website, along with complimentary registration, travel, and lodging. We are offering a stipend on a first-come, first-served basis for qualified attendees. We hope you'll join us, and we look forward to seeing you at boot camp in August in Houston.
Okay, welcome back. I think in the commercial you saw an advertisement for Cardiovascular Fellows Boot Camp. We run this here every August. There are a few slots left for the vascular track. I think cardiology is pretty full. So for the vascular surgeons out there, now's the time to get involved. It's for first year vascular fellows. And we're going to come back and finish off this case. And you'll see at the number, if you have questions, please call us with that number. It's 713-482-1108. So Ponraj. On the left, we're looking at how we made an exposure, just a little incision, spread down to the aneurysm, stuck a needle in the aneurysm, and then put a sheath inside the aneurysm sac using that guidance system.
Yep. And what you're going to see is, on the left image is what a surgeon sees, on the right is the 3D fusion, 2D 3D fusion. So anytime you do an angiogram, the CT data set is intrinsically co-registered. So this is the 2D angiogram, and this is the 3D angiogram. So as you notice, we also optimized our angle at RAO 40 and cranial 2 to be the best view, best projection to see this lumbar artery. If we didn't have all this fusion, yes, we can do these procedures. I'm not saying no, but we would have to guess these angles either from preoperative CT or shoot angiograms at multiple angles. So this is how we save our contrast and using it for our dynamic imaging upfront, so we can use it for guidance. And so I'll let this video play here. So this is us shooting angiogram and confirming our trajectory of the lumbar artery.
Okay, let me blow your trumpet a little bit. That little squiggly line that's on there was where you predicted that this lumbar artery was going to be off the CAT scan in a fused image. And so this was one of these eureka moments in the operating room, wherever you started jumping around going, can't believe that that fusion is that accurate. And those are those two arteries that we looked at on the dynamic CT scan.
Exactly. And you can see both of them very well in our angiogram. This is our inflow and this is our possible outflow. And again, the fusion process is something that needs a learning curve, but here we have a great fiducial of the stent graft which helps us with using it much more accurately. So now in this image here, we are going to see how we ended up treating this patient. After the needle is in, we gain wire access.
And so, okay, so tell us what these different lines are that we're looking at here.
Okay, so what you're seeing in the left image is this is the needle path that we planned coming from the anterior abdominal wall, and we exchange the needle to the sheath and the catheter, and that's coming in, and this wire, this red or orange line is the L4 lumbar from the right side that we have planned. And this little contour that we have mapped is the endoleak cavity that we saw in the CT.
Right.
So that helps probably identifying how much packing you need to, how much coils you need to use to pack that entire endoleak cavity.
Okay.
So now the next step is to go ahead and get the inflow vessel, as we talked about, or identifying the target vessel. So here, using the, again, we optimized our C-arm angles. So this is maybe you can talk about the microcatheter technique.
Yeah, I mean, so you've got a 4-French sheath. The nice thing is you don't need a big sheath to get access to this. We have a diagnostic catheter through that, and then a microcatheter through the diagnostic, because we really wanted to try and get in that lumbar artery if possible. Sometimes it's not possible.
So this is us having our wire through. So you can see the wire is now through. So it's kind of right behind that red line. You're through that. And then once you have your microcatheter through, then you can start deploying coils. As you can see in the bottom left is what you have the 3D overlay. On the top image you have the mapping of the so this is now the lumbar artery on the L4, L3, and this is the right side lumbar artery. So what I was trying to see is if by putting in coils, are we able to reduce flow even to the right side, because in the CT, if you remember, there was a common origin and they were very close to each other.
Very good.
So, and at the end, we finish our procedures by doing another completion cone beam CT to document where exactly our coils are. So what you're seeing here on the right image is the 200-degree rotation with a low dose scan, because we are not looking for any endoleaks. We are looking for just exactly the spatial location of where the coils are.
So we did not embolize both lumbar arteries. We couldn't get to the superior of the two, which we think is the lesser important, but that remains to be determined.
Yes.
And those coils map exactly where we were supposed to put them. Is that correct?
And we stacked the coils all the way to the same level until where the left L3 lumbar vessel was coming in.
Very good. Okay, let's see if you've got any questions that people want to ask of Dr. Chinnadurai here. If not, let me ask you a question.
Yep.
How easy would it be to generalize these kind of techniques? Let's start off with the dynamic CT acquisition.
So
this is the force.
This is from the force, but we haven't really used, okay, a few imaging specific comments. We haven't used any gating because we are looking at abdominal aorta. We haven't used any dual energy, which these are under investigation to see if we can really differentiate these endoleaks better with dual energy, but that has not been proven yet. And this is just a straightforward dynamic CT protocol which acquires multiple time points, and we don't know.
Do you need to have a force, a dual energy scanner to do this?
Not exactly. You can. There have been plenty of publications using the definition system, which is 64 slice CT scanners. So even if you have a 64 slice CT scanner, your the z-axis coverage might be limited, but still you can do dynamic imaging.
So can we distribute our technique for doing this? Okay, we have one caller on the line. Go ahead. Can you turn your volume up a little bit, please? Or turn your TV down. So even if you have uniform CT scanner, your z-axis coverage might be limited, but still you can do that. Hello, caller. Hello, caller. Good. Can you say that again?
I'm sorry, we.
Yeah, it's Rod White. Why do you have to pack that cavity when you took the lumbar?
Great question, Rod. We didn't take both lumbars. And so, in all honesty, the reason we packed it was because we were really trying to, as you pack the coils in, they kind of go into spaces where you can't directly get there with a catheter. So what we were actually using was the coil pack to back the other coils up towards the outflow artery. We wanted to get as close to that as we could. Now, I think one of the challenges and things that really needs to be developed is, as you know, the coils, really interfere with the follow-up imaging. So what needs to be developed is a coil which is radiopaque when implanted, and then that radiopaqueness disappears over time so we can use other kinds of imaging. Any other questions?
Yeah, that's what I was going to ask you then. Yeah, what do you do with the later images to be able to see?
Well, not very easily. Come on,
So
I'm going to put that to Ponraj. Yeah.
I mean, that is a known limitation with CT imaging, but there have been cases, even one of our cases, I mean, this is an illustrative case. So for example, if you see the image, this is a patient who had previous embolization, and we still are able to figure out, this is a different case that I'm showing just to illustrate this point of dynamic imaging. Even if we have artifact at the level of coils, we could still use this dynamic imaging to map out exactly where it is coming from if we are able to. So here we were tracing this endoleak to one of the lumbar arteries. So as I go through the time points, despite having these artifacts, we could tease out the diagnostic information from these scans.
But to answer your question, I mean, look, if there was an endoleak right in that coil pack, you would never pick it up.
Exactly.
I don't know anything that would let you pick that up, in all honesty, even if you did an angiography. So that's one reason we want to pack it while we're there, is because it makes it very difficult to look at that particular area inside the aneurysm again.
So again, there are some metal artifact correction algorithms, but at the end of the day, it's basic physics. If the X-rays are absorbed by the coil mass, we can't recreate those photons that have been absorbed. We can try to guess by extrapolating it, but it's not gonna be a clean image. So that's another reason to study these patients upfront correctly before we put in coils. But some approaches would, let's put in some coils and hoping that the nature will take over and promote the embolization. If the coils are in the wrong location, we haven't really done anything good to these patients.
We have another caller? No. Right, Rod, do we answer your question? All right.
Yeah, I did. Thanks.
Thank you for calling. Okay, we only got a couple of minutes left. Took a long time to go through these cases. We talked too much, but that's good. So I think we will certainly do this again, and we will look a little bit more about therapeutics, and maybe enough time to actually do a little bit more on the diagnostic part of this. But let me thank Ponraj. He's one of the few people who understands devices and imaging at the same time, which I think is ultimately the key to understanding, knowing what the issues with the devices are, and knowing particularly where to look for device failure or endoleaks, and combine that with the imaging. So thank you very much indeed. That was really
Thank you very much,
spectacular.
Dr.
Thank you very much
Appreciate the
for
opportunity.
watching.
Thank you, everyone.